Welcome to Health and Harmony Beyond the Teeth, where we dive into all subjects that will help you become healthier and happier. As a dentist, I believe dentistry is more than just teeth, so I created this show to focus on overall health. We will hear from leading experts about eating better, exercising better, breathing better, and sleeping better. We want to help you create harmony in your life so you can live your life to the fullest. We want you to thrive. Hello, everybody. This is Dr. Hal Stewart. Welcome to Health and Harmony Beyond the Teeth. I am really excited about today's. I always say that, but today this is one of my most anticipated podcasts to do because I've got a very special guest, Mike DeLuke. He is an orthodontist, and I heard him speak last month in Fort Lauderdale. We were both attending a meeting, and he was one of the speakers. And literally, I was just telling Mike, that was the highlight of the 2-day meeting, as far as I'm concerned. And I think probably pretty much everybody at the meeting thought the same thing. As a matter of fact, he was the only speaker that got a standing ovation, and it was well deserved. So congratulations on that, Mike.
Thank you.
Before we get going, I just want to just a brief history. Mike is and practices orthodontics, and he graduated from Stony Brook Dental School, and he was the class valedictorian and was a recipient of 14 academic and clinical awards. He was inducted into the Omicron Kappa Upsilon dental fraternity, and there was only 2 of his graduating class that made that distinct honor. He got his master's of dental science from the University of Connecticut, and Mike is an orthodontist that I wish we had all over the place right here in the Dallas-Fort Worth area, because he practices very unique in the way he practices and very in line with my philosophy at the Stewart Center. And so, Mike, it's a pleasure to have you on today. Welcome.
Well, Hal, thank you so much for having me, for those kind words. I'm truly humbled by that, and it means a lot to me to hear you say that about how the talk that I gave was received at the meeting. It really, I appreciate that very much.
Well, it was, we were talking earlier, and I was going to tell you, I started my career, I graduated in '89, and I started as a restorative dentist, doing things differently than other dentists did. I started very small, and every patient came through a complete comprehensive exam. I started with the periodontal health and the TMJ before I restored anybody. And one of the frustrating things that to me were the number of patients that 6 months after orthodontics started having joint popping and clicking, and orthodontists just kind of turned a blind eye to that. And I want to preface, this podcast is not to bash orthodontists. Some of my very best friend in the world is an orthodontist. And they're great people. They really are. The orthodontic community is just very dogmatic in the way that they do things. And you know more than I do, but in my opinion, things really haven't changed over the last 20 or 30 years in orthodontics. They're still kind of doing it the same way. What I love about you, Mike, is you have gone out, you know what you know, and you're not afraid to say it. And your patients are very, very fortunate to have you. I started doing orthodontics because I was frustrated with the results that I was getting from our local orthodontists. And again, they're great orthodontists in what they do. They just have a different philosophy. So we'll touch on that some today. So if you would, this is your time. I don't want to spend all the time talking. I'll jump in and ask some questions and kind of guide us. But tell me your philosophy, what sets you apart from the general orthodontic community and what's taught in today's orthodontic schools.
Yeah, I was trained in that traditional manner. I mean, UConn Ortho is an elite program. I'm proud to say it is really well known in the orthodontic community around the world, literally. Charlie Burstone, who was one of the founders of that program, is literally believed or is labeled or called the father of biomechanics of essentially modern day orthodontics. I learned biomechanics from Charlie Burstone, like literally the guy who invented the 6 geometries of tooth movement. So when I came out of there, I was trained as most orthodontists are trained, and that is to be a really good tooth straightener. And I feel that orthodontic programs are judged by how good of a tooth straightener you come out being, right? You're judged by your finishes. You're judged by how well those teeth fit together in that class 1 occlusion with ideal overbite and overjet, and how you can do really hard things orthodontically. It's not thought of as how you could maybe prevent a lot of those cases from getting that bad that you have to be such a good tooth straightener. And that's a fundamental difference in philosophy, in approach to patient care, and in execution and delivery of your services. So I say this to grant my orthodontic colleagues some grace and to hopefully give a little color to this whole discussion and provide some context that these orthodontists, and I really do believe this, and you heard me say this on stage, I don't believe that they are bad people who are coming out trying to do harm to their patients. They're trying to cause airway problems and TMD issues and relapse later in life. I truly don't believe that. Now, obviously, there's outliers and everything, so can't say 100%. I would just say I've been teaching, coaching, involved in academia and private practice for over 20 years. I have met so many different people in so many capacities in my profession. By and large, they all want to help their patients. That's why we all went into this, whether we're in ortho or general or pediatric dentistry or whatever it is. And so I started to realize, well, if they really want to help their patients, why? When I start talking to them about ways that we can help our patients younger and more proactively and more holistically, why do they hate me for it? Why do they literally try to silence me? I mean, I've been silenced off of our online social media platforms. I showed some examples of some of the lovely things that are said to me and about me in my talk that were direct screenshots of some of these platforms. And so I spent a lot of time thinking about why that is. And ultimately, orthodontists, we're all victims of our education, and we're all victims of what we were taught. We feel like, especially as we get into be orthodontists, we have pretty good egos. We've done well throughout school. We go through this additional training, and I'm going to come out and you're going to tell me, and not just you as Dr. Hal Stewart or as a general practitioner, but you, anybody, you're going to tell me that I don't know what I'm doing here, that all this time I spent in education, all these faculty members and administrators in our orthodontic programs who have told us this is how you do it. This is the science. These are the data. They're wrong. And if you think about it, I mean, that's how dogmatism really starts. These orthodoxies are propagated by people who strongly believe what they're saying and tell you there's no room for negotiation or debate. And that's really what happens in your orthodontic residency training for the most part. Now, there are some outliers. I'm affiliated now with Montefiore Einstein up in Bronx, and I do virtual teaching for them. Their director, Marej Ahmed, is amazing. He gets it. He's their chair of their department. He recruited me in to try to help me teach the residents these concepts of early treatment, airway focused care, some of the things we can talk more about today. So there are isolated pockets where they get this, and it's amazing. The residents just soak it up. They love it. These young docs want to be more than just tooth straighteners. The old guard, they don't really want to change. And again, we spoke a lot about this in my lecture in Fort Lauderdale. Just to summarize it, it's hard. Change is hard. When you look, we're running these busy practices, seeing 75, 100 patients a day. We're told by our consultants, get out of the consult room as fast as you can, because you're going to say something that is either opens up Pandora's box or is stupid, or, you got to double talk to the parent. You got to double the time that you're going to talk to the parents about this topic. And you could just say it in one sentence and get out of there. We're told, doc, you know what you're going to do as soon as you look at that patient in those images. You've straightened a lot of teeth before, don't overthink it. That's how we're taught. And then the consultants in our industry propagate that by feeding that ego of like, you make your money in the clinic straightening teeth. Now you get a guy like me that comes along and says, you have to, I shouldn't say have to, I'm telling you what they have to do, but I suggest, or if you want to have a different perspective and a paradigm shift in our profession towards one of proactive treatment, you've got to go in and look at these patients younger. Well, I don't know how to handle a 5-6-year-old kid. I was never taught that. We are never taught that. We don't have behavior management as part of an orthodontic residency. None.
Yeah, not this, but
No, please.
in the orthodontic residency, when do you start treating? When do they say to start treating kids?
AAO, American Association of Orthodontists, says on their website by the age of 7. They don't say at 7. They don't say not before 7. So some orthodontists will say, oh, the AAO says wait till 7. If you look at their website, they don't say 7 as far as to wait till 7. They say by the age of 7. They even say that if problems are detected in symmetry, growth, development, tooth positioning, and eruption, you should see the orthodontist prior to the age of 7 on the website. One of the problems that they list that you should see the orthodontist for is mouth breathing on the AAO website.
Mm-hmm.
So these orthodontists that say there's no place to see kids before the age of 7. And I mean, hell, I've had people say to me, and I've heard them say to others, it's malpractice to go in and start treating these patients before the age of 7. There's no evidence basis for it, which is completely false.
Right.
They say these things to scare and intimidate and back people down, because who in their practice wants that headache of now? I mean, I know people have been literally turned into state boards because they're treating kids younger with orthodontic focused treatment. And that's intimidating to a lot of people. And the establishment does, meaning academia and sadly the AAO in a lot of ways, and their scientific committee who determines who speaks and who gets to have a platform, they don't want talk of this. I think there are a lot of people probably sitting there thinking, why? Like, why would they be against this? But if you think about it from the administrative standpoint of the establishment of, say, academia and the AAO, they've doubled down on this. They have said for such a long time, well, orthodontic treatment doesn't cause jaw joint problems. Orthodontic treatment doesn't cause airway problems. Extraction of teeth.
Go back now.
Right.
Yeah.
And that, I think they're fearful of liability. And I think they're fearful, what if we say something like that or even indicate a hint of that, then the orthodontists, because not every orthodontist out there is going to all of a sudden change. And if you've been practicing for 25 years and you've been doing it the traditional way of wait until they're older, extract teeth, right? Cave everything in, line it up, try to get it class 1 with good overbite and overjet, and not have any awareness of tongue space or lip support for the most part, or airway. Not a lot of people who have been practicing for 2-3 decades can like transform their practice at that point. It'd be like if you had done restorative for 30 years and all of a sudden you're like, and I know people who have done this, I've actually coached some of them. And like, I just want to start treating patients younger and earlier to be more proactive, but it's very rare to find somebody who can take that lead.
That's exactly what I did.
So you'd been that long before you
practicing 35 years. I know I don't look like it, but
you don't. No, you look great, and everyone
but
guessed.
about 10 years ago, I started seeing, and this is where orthodontists don't have, in their defense, they don't have the luxury of seeing patients through their entire lifetime like we do.
Thank you.
And I remember a dentist, one of my professors, he said, when you get out of dental school, you're going to see all this treatment and you're going to say, this needs to be replaced. I don't like that crown. That he said, at about 5 or 6, 7 years, you're going to say, this crown really needs to be replaced. Who did that? And you're going to go, oh, wait a minute. I did that.
I did it. Yep.
Orthodontists don't have that luxury. So as a general dentist who specialized in TMJ and restorative, I saw the after effects 5, 10, 15, 20 years down the road after they had left the orthodontist. The orthodontist never saw that. So I came to the conclusion 10 years ago when I really got into Airway that, we need to, there's a lot more to just stabilizing the joint and then restoring the occlusion. We got to go back. We got to go back to Airway. And then once I went down that rabbit hole, of course, I said, we got to start seeing kids. I never saw kids in my practice until about 8 years ago.
Wow.
Never. And we don't do
good for you
industry, but we see kids. My wife does, we both did residencies with the Breathe Institute. She does the infant tongue releases and I do 4-year-old. She goes up to 3. I do 4 and older. Wow. And it's been great. I would rather fix a sick child than a broken adult. We do treat broken adults, but it's a lot easier to fix a sick child. So in the defense of the orthodontist, each individual, they don't see the results 5 or 10 years down the road. And I wish that there was standard of care where you should recall your patients every 5 years. You kind of follow what's going on with them.
Right. I agree. And first of all, kudos to you. You are one of those outliers. That is not easy. And having come from a family of general practitioners,
Yeah.
I know that when you got that reputation in your community and you're doing quality restorative work to transform what you're doing. And as I said, I've coached some docs through that process, and it is not easy. So it's awesome. Yeah. And the fact that you did that in the name of patient health, there's a gentleman I coach and work with. He won't mind me mentioning his name, Scott Province. He's awesome. He's up in the Northeast. He was at the meeting too, in Fort Lauderdale. And Scott is similar to you, practicing New York City and Park Ave, and had, I think, 20 plus years in this practice, maybe even 25. And same thing. And it started with seeing his kids, and he was seeing things, learning more, hearing more about airway growth and development, trying to get orthodontists in Manhattan to pay attention to his daughter. I can't remember that point was his son or his daughter, one of his children, to start to understand maybe they could help this child a little earlier. And I think we're thinking like 8, 9. This wasn't even super early. And every orthodontist that saw the child just said, nope, wait, too many baby teeth, wait. And that sent him on this journey to start to learn more about airway and what could be done for younger kids. And I also love what you said about the orthodontists not seeing their work down the road, because I have found that a lot of the orthodontists who do get this or see this as I see this and as you see this did some time in restorative. I spent 3 years moonlighting in my family's general dental practice when I was a resident at UConn. Interestingly, we weren't supposed to moonlight, so I didn't tell anybody I was doing it, but I was performing very well in the program, so no one knew. It didn't take me away from it. I did it on 1 to 2 weekends a month. I would go do this at my family's office, which was a couple hours away. And I learned, it started just covering emergency call and kind of doing something. And then they were like, geez, we're really busy. It was a multi-doc practice, and this patient's been trying to get in for some restorative and some basic routine crown and bridge. Could you do some? Sure. I was fresh out of dental school. I was really well trained out of Stony Brook. Great. Let's do it. Make some money and learn. Well, I started seeing exactly what you're describing, Al. I'm seeing these patients that all week I'm extracting 4 buys on these people and caving everything in, and can't figure out why it doesn't fit and why it's almost impossible to get rid of the full class 2, and they're still retrognathic, and really not understanding what I was doing, but just doing it. And then I'm on the weekend, I'm seeing these patients, and that same patient is a 40-year-old female falling asleep and snoring in my chair while I'm trying to do some basic restorative on her. And she's got dark circles under her eyes, and she's got a list of medications she's on. And she's telling me that some of these patients have been prescribed drugs. They're seeing psychologists or psychiatrists. They are taking medication for psychoses that they have been diagnosed with through going through divorce, having all sorts of marital and work-related issues, because, as you know, this, especially with restorative, you get to know your patients, they start talking more. And I'm like, and I didn't realize it at the time. I think it just sat with me subconsciously that I can still, to this day, I can picture those patients that looked like that and presented like that. And almost every one of them had orthodontic treatment and had really narrow arches, and many of them had teeth extracted. And if I could, on that moment, I want to talk to the question of if extractions cause airway problems. Can I go there for
Absolutely.
a minute?
Yeah. If you weren't, I was going to.
Perfect. Yeah, I don't want to jump the gun on you with it, but it's such an important conversation, and it's something I often speak about as well when I lecture and teach. So, and I just posted something about this in one of our orthodontic groups online yesterday, where the whole conversation and debate over whether orthodontics, and for that matter, extraction of teeth, causes an airway problem, to me is the wrong conversation to be having. And I feel like the orthodontists want that conversation because there are no data to prove otherwise. Mm-hmm. So it's really convenient for them to say, show me the data that when you take a patient and pre-treatment T0, that patient gets evaluated for sleep. Now, they tend to use polysomnography in the kids, which that's a whole nother, we do a whole episode on why that has issues and isn't really the end all be all of judging whether a child has sleep disordered breathing or not. But let's just go with it for now. So let's just say you use pre-treatment polysomnography and then immediately post-treatment polysomnography. And that's how most of these studies are conducted. And what they say is there's no change in airway. That patient doesn't get more apneic or have worse, an AHI that goes up. There aren't studies showing that. When they look at pharyngeal patency, now it's funny because if I want to show where something I did improved, even on 2D, because it's a whole nother conversation why orthodontists aren't embracing 3D imaging, but let's just stick with 2D. If I show, look, the oropharynx and nasopharynx look larger in this 2D lateral cephalometric imaging post-treatment versus pre-treatment. They say, well, you can't tell airway off of 2D. But if you look at the studies that talk about whether extraction impacted airway, they look at 2D cephs and say, look, pharyngeal airway didn't change. So the reason being, again, where's the literature coming out of? The educational institutions.
Yeah.
What's the last thing the educational institutions who have been teaching and continue to teach extraction orthodontics ever want out there? That extraction orthodontics causes problems.
Right. Yeah.
So I've said, because I've gone down this road.
Also, could it be, I mean, these patients, they already had a restricted airway.
That's it.
Before, so their polysomnogram's not going to look that much different because you may have went from really bad to a little worse, or and that's going to catch up with them as they get older anyway, because as the airway collapses because of laxity of tissue. So
you nailed it.
Research can be flawed, like, as you well know.
You nailed it. And that is what that's what I've reframed the debate to become. And this is what I just said yesterday to somebody. I said, the whole do extractions cause airway problems. We have to get away from that discussion on both sides, on the ones of us who are trying to stop a lot of extraction of teeth for the implications for the airway, and those who are doing it and they think it's fine. How about we look at it? You said it perfectly, Hal. That patient at T0 already has the airway problem. If they didn't, you probably wouldn't need to be extracting teeth. We know, and there was a great study in 1983 in AJO, which is now AJODO, by McNamara, O'Connor, and Howe. And McNamara is a huge name that most people will know. He's out of Michigan, Jim McNamara. And they literally took the dental casts of 104 patients, and approximately half of them had severe crowding and approximately the other half were no crowding. And they measured the teeth and they measured the arch forms. Literally 100% of the cases were due to small arches, not macrodontia. Not that macrodontia is never a thing, but generalized macrodontia is really, really rare. And so when we see crowded patients,
those that might be listening to this that are not in the field, macrodontia is unusually large teeth.
Thank you.
And that's rare.
Yeah. I mean, you might see one tooth that we call a macrodont, singular. You might maybe even like both central incisors in some patients will be really large, but you just rarely, you'll see generalized microdontia, small teeth a lot of times on a lot of patients, but you just rarely see somebody with these huge teeth. So the only other thing that can be causing the crowding, if it's not big teeth, is small jaws. And so why are the jaws small? Well, in many patients, the way they have been breathing since they were little, meaning 3, 4, 5, 6 years old, has caused the inward push from the orofacial musculature to collapse the transverse dimension of the face. And as a little tangent, many of my orthodontic colleagues actually deny that that's even a thing. They literally do, even though it's all over the literature. I mean, I could spend an hour studying literature on that. They deny that there's anything called adenoid facies or rhinitis face. They feel that you're genetically programmed to grow, and that's what you're going to do. And they don't believe the functional matrix theory of Mel Moss. Those people, I don't think we're ever going to really convince because they're very dogmatic. That being said, most people would agree.
Do they not believe in epigenetics?
You took the word out of my mouth. I say most people would agree in the concept of epigenetics, and it applies across all disciplines of science and medicine. Yes. So we know that there's this impact of our environment on craniofacial growth and development. So, which is proven. So if we have that and we can stop that from happening earlier, I said, what we need, and it would take many years to do this, but what we need is a study that says, I'm going to take my patient or your patient at 3, and we're going to treat them with our protocol. And we're going to, at 15, look at that patient's airway, sleep, behavior, et cetera. And we'll take your patient at 3, and you're going to treat them with your protocol, which is waiting, watching, the traditional protocol, wait, watch, let the crowding get really bad, try to clean it up with braces as an adolescent, and then look at their airway health and behavior at 15. Now, again, because of ethical principles and limitations in being able to conduct these long-term studies with children, it would be almost impossible to conduct a study like that over that period of time. Not impossible, but it would be very challenging. But if you could, those are the data we need, right? How does my patient fare with my protocol starting young? And because I agree, if I get that patient at 14, or excuse me, 12, and they have impacted canines and zero space for any of their teeth, and the canines are heading towards the laterals and they're going to resorb the laterals, sometimes you can try to make space at that point, but sometimes if there's literally no for those teeth, what other options do you have at that point? And I have pushed the limits of what's possible doing that, and I can get space for just about anything. But I also prided myself on being a really, really good clinical orthodontist. If you don't have that type of skill set, or you're not comfortable with that, which not everyone does, the crowding gets so severe sometimes. You're like, I got no choice. And then you add on that most orthodontists still think you can't expand the mandibular arch. And you can see why this all feeds into this, like, well, I can't do anything about it anyway. Extractions don't cause airway problems. And I often say, I agree, because guess what? I don't believe that someone, to exactly your point, Hal, someone walks into the oral surgeon's office at 12 to get teeth extracted for premolars at the recommendation of the orthodontist, and they have a perfect airway and they breathe beautifully. And then that night they have detectable obstructive sleep apnea. I just don't believe that happens, right? No, because that patient that walked in most likely already had the airway problem. And even if they didn't have one that was really clinically detectable, they're at a greater chance and risk of developing one later, because studies and data are very clear that patients who suffer from OSA as adults typically have narrower arches, higher vaulted palates, right? Longer vertical dimensions, insufficient tongue space. So I feel like we need to reframe that discussion and that debate and get away from the whole extracting teeth causes airway problems, because it just puts the orthodontist and the orthodontic profession on the defensive. And it's not really productive, because there's no literature now, and there really isn't ever going to be any, that proves otherwise. So what do? We have to think smarter and say, no. You show me a patient that started looking like this at, even, let's just go with 5, 6, 7 years old, right? Let's not even go be earlier than that. That ended like my case ended up. And this is what I do a lot when I teach and I lecture. I want to see one that you started like this with your protocol that looks like mine does at the end. Because a big part of their argument is, well, it's just anecdotes, right? It's just one-offs. Now, we do have a responsibility, the people who think like you and I, we have to start gathering more data, and I'm working on some things to do that. But data is important, and data are important, excuse me. We need those data to be able to substantiate what we're doing. That being said, in the meantime, while we're in the process of gathering data, we can show, and I say that I challenge people all the time when I lecture, I'll show a case. And I call it gets beyond what I talked about in Fort Lauderdale, but to explain it to you and your audience, what I do, I call it, if anybody's read Peter Attia's book, Outlive, he talks about medicine 1.0, 2.0, and 3.0. And he says medicine 1.0 is like Hippocrates, days of bloodletting, really very little science involved, right? You just kind of get all off clinical. 2.0 is traditional Western medicine, which is reactive. It started with infection control and germ theory, antibiotics, but everything became about treating the symptom. And he calls on medicine to go to 3.0, which is proactively preventing the problem from happening. And so when I was reading the book a couple of years ago, I said, we have the same crossroads in orthodontics. Orthodontics 2.0, we need a fundamental paradigm shift. Orthodontics 2.0 is that traditional straighten the teeth to put the models on the table and make them look like everything lines up. You don't look at the face. You don't look at the patient health. You don't go in a proactive approach. You're not interdisciplinary. You don't really care. You're not looking at working with your ENTs and your allergists and myofunctional therapists. What the heck do they have to do with straight teeth? I'm the orthodontist. It's my job. That's 2.0. 3.0 is what you and your wife are doing. What people that were at the conference with us a few weeks back were doing, right? Proactive. Taking the time to diagnose your patient, understand why they are presenting like this, and try to prevent them from getting so severe.
Yeah. I want to tell you a quick story that kind of relates to this. About 15 years ago, when I realized I wasn't treating airway, I was stabilizing joints before I was short occlusion. I had a case that I had stabilized their condyles, the TMJ, and mounted the case at first contact, because when you get this stable, the bite doesn't necessarily line up, as you well know. So I did my own little experiment with 5 orthodontists that over about a 6-month period. The I took one articulator and had the models mounted in MIP, just the way the patient came in, their bite.
Yep.
Another articulator with the models mounted after the condyles have been stabilized. And I know this doesn't have anything to do with Airway, but it's the point I'm making is I had the orthodontist over to my office, provided lunch. I showed them, hey, I want to talk to you about a case. I showed them the first case. What would you do here? They said, oh, I would do this, that, the other. Then I got the other articulator with the same patient, but the bite was with stable condyles. And I said, what would your treatment plan be for this one? Oh, well, on this case, I would do this, and sometimes it was not the total opposite, but it was a significant difference.
Yep.
Treatment. And then I would, pull the curtain back and say, this is the same patient, but unstable joints and stable joints. If
What
this
did they say?
walked in their office, they would have treated them the first way.
Yeah.
They were, oh, that's really interesting. And then I would never hear from them again. So I've been at odds with the orthodontic community forever. But then I realized about 5 years after that, hey, I wasn't going back far enough. The reason these patients had TMJ issues is because they had airway issues.
Yeah.
So it's like, okay, well, let's regroup and learn how to treat that.
Yeah, I love that. I think it's another example we were talking about before, right? We are taught a certain way. Now, there isn't a discipline of orthodontics, the kind of the Roth doctrine or principle where they mount cases and articulate every case, trying to find a CR that they will then treat to.
Right.
Most orthodontists are not doing that, especially in busy practices. I wasn't. And when I was at my busiest point and being, before I was aware of kind of what I was doing on a bigger perspective. I mean, I wasn't trained to do that. And in a way, interestingly, as I kind of evolved different concepts, I found out one of the best things I ever started doing, especially in my adult cases, but I did it in almost every case anyway. So I understood it, is I disoccluded essentially every patient I treated for comprehensive ortho with a bite ramp or bite turbo and I found when I did that, all my cases treated out better, because I was essentially deprogramming them without even knowing what I was doing. I was literally just trying to do it to unlock the occlusion, because occlusion can be very retentive and it's harder to move teeth when they're in occlusion. So I was just trying to deprogram them, and just kind of in a more vague sense for my ease of orthodontic treatment. And then I started to realize a lot of these adult patients are coming in and they're like, geez, my jaw feels so much better already. Like their first adjustment visit. And they're like, gosh, could it make a difference that fast? And it took me a few times to be hit over the head with that, to go, oh, wait a minute. I'm basically deprogramming them and letting them find a more comfortable neuromuscular position. And then I can kind of treat to that. And it led to tremendous advances in my stability and success of my especially adult comprehensive treatment. Also, to your point, I literally just had a family friend email me yesterday, who I treated her boys. And now that I'm in Florida, I'm not in upstate New York anymore. She had gone through some Invisalign with someone else up there, and she's relatively happy seemingly with the results of the case. But she said, ever since I went through it, and you already know what I'm going to say, my jaw joint is killing me. It's clicking, it's popping. I wake up in the morning, and this didn't used to happen before. So we don't know what we don't know. And when you're focused on just straightening teeth and getting class 1 occlusion, you can ignore a lot of things of the somatic-gnathic system. It's really convenient to just put those blinders on and tell the patient, oh, well, and you probably know this. What did the orthodontist, because she went back to the orthodontist, what did the orthodontist tell her? You're clenching your teeth. It must be stress.
Right. Yeah, I had one.
And I'm not pointing fingers. I have done that to my patients in the past. So I'm not indicting this person. Like, before I understood better, I said that a lot of times. So I don't want to be hypocritical here. Like I just think that's what we're taught.
Right. I had one orthodontist tell me, because I sent a patient back to him, her joint was clicking, she had some interferences, and I said, take a look. he called me and said, "Hey, if I had to retreat you know, tweak every case that has popping joints after I'm done with them, that's all I'd be doing." And I'm going, well, that should tell you something.
Right? Like
Maybe
light bulb.
it's a little differently.
Yeah. I mean, really, it's, but again, we're taught that. So, like, without diving too deep into the weeds on this, there was a lawsuit in 1986, I believe it was, where it was the biggest settlement, I think, to date still. I think back then in those dollars, it was like 1.2 million, something. It was a lot, um, for against an orthodontist for causing harm to someone's TMJ apparatus and causing a TMD essentially. And I don't know the particulars of the case, but it was a landmark case. And you started to see after that tons of orthodontic literature coming out to say orthodontics has no impact on the TMJ and moreover TMD. And I always said, even as a resident, I'm like, I don't understand this, because we were taught that. We're like, nope, nothing, orthodontics does not cause problems with the TMD. It's in the literature. Well, they did that to CYA after there was a huge lawsuit, because they, I feel, know it does and can, obviously, in a lot of ways. It happened in some of my cases. And when you start to really look deeper into it, it's very convenient, but at the same time, it makes no sense, because I know for a fact, if I treat a case well, I can help a patient's TMD.
Right.
So if I can help alleviate it with orthodontic treatment by moving the teeth to a different position, how can we plausibly say that the converse can't be true and I could harm it by putting the teeth in the wrong position? It
Yeah.
never made sense to me. I'm like, this just is, the two things are mutually exclusive. You can't have both existing at the same time. Um, but people will do a lot of things to protect their interests, right? I mean,
Well, you know, the whole medical industry is based upon it's, you know, it's multi-billion-dollar industry based on treating symptoms, and
yeah,
that's hard to change. But you know, there are people out there that are doing it, in my opinion, the right way, like you and we're doing it, and others. I mean, that room last month was filled with doctors that are doing exactly what we're talking about.
yeah.
You mentioned earlier, and I wanted to ask you about this because, interestingly enough, I was in a conversation with an orthodontist. He was fighting to keep his patient, and I was just telling mom, as a 15-year-old boy, what I would do. I didn't say your orthodontist did anything wrong. I just said, if this were my patient, here's what I would have done. So he and I were in a conversation. I told the mother that I knew her son was about out of ortho, and he was about 8 or 9 millimeters transverse width short of what he really should be. And
Mm-hmm,
you know, on a 15-year-old, we can still expand, as you know,
mm-hmm,
tremendously. And so that was so it was all involved with that. He told me, he said, you can't expand this kid anymore. And he said, even if you could, you cannot, absolutely cannot expand the mandible. So
thank you.
tell me your
Thank
thoughts
you.
on expanding mandibles.
So now, I'll qualify this by saying, and actually, he's going to be coming on my show soon. We had to reschedule; he was sick. But Joseph Yusefian, who's an orthodontist out in, I
Oh,
believe, Seattle,
I know,
you know,
Joe.
Joe.
Mhm.
So he does something called telegnathics, where he's actually they're doing some parasymphysial cuts in the mandible and putting distractors in. Absent that, like, we'll kind of put that aside for now. The traditional way people talk about expansion, because the mandibular symphysis is pretty much fused around the birth period within that first year of life, whereas the maxillary midline suture, for those in the audience who may not be aware of this side of it, or the laypersons on the anatomical side, is like a zipper. A suture is essentially a zipper that where two bones embryologically come together. And in the mandible, it happens very early in life. In the maxilla, it happens much later in life. So the bones will approximate one another in the upper jaw. But there's a great study in 1975 by Bert Melson in the AJO, that she talks about the fact that, actually, that might have been in JC Journal of Clinical Orthodontics, I think it was. She shows histological slides of coronal slices of the upper jaw, of the maxilla. And you can see that, she calls it, under the age of 10, the infantile period. It's like a wide open highway through the center of the country. I mean, it's just, there's no interdigitation of the bone. It's all essentially just cartilaginous material that is really easy to expand and grow. Hence why it's so easy to expand the young kids. To your point of the 15-year-old, that bone is now and the adolescent stage, she calls it, which is, there's a lot, if you look at it histologically, it's like a windy, curvy highway, right? It's really torturous. There's a lot of bony interdigitations, and it's much harder to get that bone to separate. As you said, we still can, and there's certainly ways to do it, but it's just not as easy to do at 15. So that's kind of the overview of this whole conversation of like, why could you not expand at 15 versus at 5? It's really easy. Now, that's the upper jaw. The lower jaw, that bone's pretty fused, that suture's pretty fused early on in life, certainly by 15. So orthodontists are taught you can't expand the mandibular arch, but we conflate that with saying you can't expand the mandible because of the sutural anatomical differences. I don't know why, but because they're two totally different things. Expanding the mandible and expanding the mandibular arch are different concepts. I agree. You can't orthopedically expand the body of the mandible across the sutural. You can't get sutural orthopedic change without something like, you know, a cut, distraction osteogenesis. You can't do that orthodontically. Point conceded. Where do we get this idea that you can't get dental alveolar expansion and dental tipping and uprighting of caved in lower teeth early in life or at any point in life? And this is where it gets so crazy to me. So Schwartz and Gratzinger came out with the Schwartz appliance in the mid-60s, 1960s. That has been widely accepted in the orthodontic profession, and it's all over our literature for the past 60 years. Yet we say you can't expand the mandibular arch. How is that not? I mean, McNamara had another great study in 2003 in AJODO, and they looked at, and it's a great long-term study over 20 years. They actually looked at patients that were treated with no crossbite and had upper and lower expansion versus just upper expansion. They followed these patients over 20 years, and they found that short and long-term, those who had lower and upper expansion did better arch form, more room for the teeth, better overall results and stability. So it's in our literature. Yet, Hal, I talk to orthodontic residents at many programs throughout the country, and they tell me they are taught by their directors that expansion of the mandibular arch is malpractice.
Wow.
That expansion in the absence of a crossbite is fundamentally wrong, and they'll be kicked out of the program if they're ever caught doing it.
Wow.
So this is where the dogmatism just takes hold, and you just start to shake your head. So again, just to kind of finish painting that picture, when you get a patient that is in your chair at, say, let's just go with 6 years old, and you see that patient, because that's a lot of times, sadly, they're not even getting to the orthodontist office before that, just because of a lot of reasons. But let's just go with 6, and they have no crossbite. The orthodontist looks in that mouth and says, there's no place for expansion. Or maybe if they're really crowded, the orthodontist will put an upper expander in, and they'll try to expand it as much as they can without putting the patient into a Brody biter where the upper is completely outside the lower, and then take it out. And what happens? Everything goes back. It ends up not working. And the patient still probably ends up needing teeth extracted or needing more expansion or treatment later. And the profession, and we have literature and studies that show this, the conclusion is that phase 1 doesn't work. My contention is nothing works if you don't do it properly. Like moving teeth with plastic. If you don't understand how to do digital setups, things like Invisalign, whatever aligner system you're going to use, doesn't work. Crown and bridge. If you don't understand the fundamental principles, right? It's not, you're not going to have retention. You're not going to have stability and long-term structural integrity of your restorations. Just because you do it the wrong way doesn't mean it doesn't work. So what could you do? What I developed doing early in my career, I shouldn't say developed, it was being done by others. I didn't really understand it. I just started seeing the need. I look at these kids and I'm like, 6, 7-year-old kid, really crowded anteriorly, not enough room for the lateral incisors to come in, no knowledge of airway, breathing. I mean, none. We're going back, over 20 years ago. And I'm like, I don't feel good about pulling teeth on this kid. I don't. So I started doing more research. I'm just out of my residency where I've read nothing but research for 3 years. I go back and do more research on lower expansion, which we hadn't learned about. And I started uprighting and pushing out the lower slowly with Schwartz type appliances. And then I went in and got it so that the molars were upright over the bone and developed the arch, went in and expanded the upper. I started seeing like, oh my gosh, the teeth have room. And it was at that moment that I started to understand The teeth aren't the problem. The teeth are the symptom. And I still no knowledge of airway at that point. It was well before I had any comprehension of airway and breathing and the impact I was having on that. And so that's just to try to paint that picture a little bit for people of why the orthodontists feel this way, because we are literally taught that you are not allowed to expand the mandibular arch. I heard my former director at UConn. I was standing right there, and a guy who had just graduated the year before was out practicing in California. And one of the other residents who was still friends with him said, yeah, he's so-and-so's telling me, he's showing me these great cases where he's going in and expanding the lower in these younger kids and then doing the upper. And right in front, it was right before a case conference. My director said, I should have the ability to take your degrees away from you when you get out of here and do stupid bleep like that.
Wow.
Think about that. And now this guy, the director, I won't name him, there's no point, but he is a international name in orthodontics. I mean, he is known across the world. So, and I'm not even pointing fingers at him. It's because it's endemic to the profession. Like, that is how strong he wanted the ability to revoke his orthodontic certificate because he found out that in private practice, he was expanding the lower arch in younger patients. So anyway.
Dogma to the nth degree.
Yeah.
So, just kind of a general overall view, and we'll wrap up here. I like to keep these at about an hour. I think the viewership, that's about, a lot of people like these 45 minutes to an hour. We can always do another podcast, and I would love to actually. Sure. But just in general, if you had to make a broad statement on airway, breathing, sleep, and how it relates to orthodontic or jaw size or arch size, what is your overall philosophy on that?
Yeah, it's a really great question. I'm happy to come on again to do this. I love helping get the message out about this, and as you can tell, kind of defending the orthodontist, but also being really hard on the orthodontist because it's an interesting role to play. But I don't mind it because I really believe in this, and I believe in my profession, and I want to see us do better. So the question you asked is tough, and I'll start by saying what I always say to anybody about this is the etiology of an airway of, let's just go with pediatric sleep disorder breathing. The etiology is multifactorial. Therefore, the solution needs to be multidisciplinary and multifaceted. So we can't just look at a patient A and say, and that's kind of the rub on why this is so hard, because we're not taking time as diagnosticians in the orthodontic practice. And that's fundamentally what to me is holding back the progress, because this, to answer what you just asked, it comes down to the diagnostics, because what one patient might have as their presenting symptoms might be completely different from another one. And we also have to get away from this whole like expansion cures airway. I just had that debate with somebody online, and I said, they were trying to say that's what I say. I said, I find a place that I've ever said that. I've never said expansion cures all airway problems. Of course it doesn't. I mean, we heard at Airway Palooza, Stanley Liu was talking about it. He's like, I can give you the biggest airway you want. But that doesn't mean you're going to not have some sort of sleep disordered breathing, right? Because it's multifaceted and multifactorial. So I look at it as, well, in that particular patient, our job is to be diagnosticians. That means we need a really thorough patient history. We have to dig deeper. Most orthodontists, what are we doing? And I was guilty of this for many years. Again, I'm not throwing stones here. I was there. You look at the basic medical history that they fill out, and unless there's anything that jumps off the line on, say, a cardiac abnormality or some significant medical history on the meds that the child's taking. I mean, we see ADHD all day, every day. We see it being medicated with essentially methamphetamine, and we don't even bat an eye at it. Like, I didn't. It was like, oh yeah, wow, a lot of kids are doing this nowadays. I had no idea that I could potentially, and oftentimes did, help that. None. And so we have to look at the overall picture of this patient. And this is a lot of what I help people with and coach people through, orthodontists and non-orthodontists, because it's easy to look and say, well, let's just go in and try to get every young patient to be this millimeter width of their molars, right? Well, then you go do that, and all of a sudden that doesn't work on this one patient. Well, why or why not, right? Because it's not just about the expansion. People took the article that came out from the American Academy of Sleep Medicine. Was it American Academy? Yeah, I think that's what American Academy of Sleep Dentistry. And they put an article out recently, a couple of years ago, maybe a year and a half ago, and it talked about the fact that no monotherapy is, they scoured literature and found that no monotherapy works to improve airway consistently or sleep disordered breathing consistently, especially in children. They looked at adults too. And there was this big thing like, see, people were posting on the ortho group, see, we told you expansion doesn't help airway. I said, that's not what the article is saying.
Right.
It's saying that there's no magic bullet, just like a release of a tongue tie isn't going to solve it in everybody, right? Just like removal of adenoids and tonsils, not going to solve it in anybody. That's the gold standard to this day, listed as the gold standard for treatment of airway obstruction in children. Yet the Bhattacharjee study from 2010 said that only 20% of patients, when they were followed from 40 to 720 days post-surgery, only 27% of patients had complete resolution of their airway obstruction post-adenotonsillectomy. So why didn't that work? Well, we didn't take into account maybe they have allergic rhinitis and they can't breathe through their nose, or a severe septal deviation. It's so multifactorial. And so our job to figure that out and figure out what we're looking at in this patient and what the impact of orthodontics is, or why these patients need to be treated, is to look at why they're suffering. And so what is the problem? And I think the ADA did a brilliant job with this. And Steve Karstensen, who's become a friend, it was part of that group. They essentially, in 2017, they put out a position statement. And to summarize it, they said every provider, every dental practitioner professional should be screening for airway compromise in every patient. They should then be coordinating care with their medical and dental colleagues as needed, and perform evidence-based treatment to try to achieve an establishment of a physiologic airway that facilitates nasal breathing. It's not more complicated than that. Like, that's literally what our why should be and what we should be in our objective all the time. Sometimes that's going to require working with the ENT. Sometimes it's the allergist. Sometimes it's both. Sometimes it's a myofunctional therapist. Sometimes it's a tongue tie release. Sometimes it involves expansion, and we've got to get in there. Sometimes we can make appliances to just help facilitate nasal breathing for these younger patients and just help get them get the tongue position in the right spot. But that becomes why this doesn't fit well into the average orthodontic practice, or even the average busy general or pediatric practice. The extra time to do this, investing in additional imaging like CBCT, 3D imaging, understanding how to read those images, having the extra data storage, having the software on your computers. You're running a busy practice. I understand the logistics of this. It's hard. I did it. It's not easy. And now you've got to train your team differently. And you did it too. So again, tremendous credit to you for this. You know all this. You've got to change your systems, your scripting, your scheduling. The way that you approach your day is totally different. And when it's just much easier to not think that way. So that is the challenge in it. But again, it's a long answer to the question of what seems, kind of a straightforward question is, it depends. Because you have to be able to understand what's happening. And my goal is always, and take this, Jeff Rouse was on my show a while back, and I said, Jeff, I'm going to steal this, is normalize anatomy, right? We've got to normalize anatomy. So I'm not a huge treat to a number guy in anything, whether it's a Ceph or whether it's an intermolar width. Like, there's ranges you want to be within, right? I mean, obviously, there's extremes. There's way too small, and you want to get certain sizes. But I look at it as, it's not just the molars. What about the primary molars? What about the canines? One of the ways I realized how much more of an impact I could have is sometimes I didn't need as much expansion across the molars as I was getting. I needed more across the middle and anterior thirds of the arch, where the tongue really needs the space. We've all had those cases. If you just expand a patient who's narrow and has those V-shaped arches, you expand them. They're way wide, right? They're way wide in the molar, and they still have barely any space anteriorly. Well, the tongue still doesn't fit. And those patients still usually have a higher vaulted palate. Even though you've blown the molars, they could be 45 millimeters. So again, that's what I mean. I don't treat to a set number, because in that patient, it's more comprehensive than that. We have to think about it that way. So I know that was I apologize for the long answer on that, but I felt it needed to be gone into a little more detail as to why I have that belief.
I think it's great. The more that you talk, the more I realize our practices are very identical. But every patient we see, we look at 5 zones, really, well, 4: the nasal passages, the nasopharynx, the oral pharynx, the oral cavity, and the TMJs. So we're looking
Love
at
it.
all of that. Four of those directly affect the airway. And so you're exactly right. It's a team approach. I mean, every single patient we see, we do an ENT consultation because we can widen the arches all we want. And if they've got a deviated septum or enlarged turbinates, an airway has to be patent all the way
Yes.
from the nostrils to the lungs. It's got to be
Yep.
patent. And if we're just throwing appliances at people, that's one part of the journey, but
Yes.
it's really not the whole thing. That's where as I've gotten older and hopefully wiser, I've really enjoyed the diagnostic part of it and
Agreed.
sitting down with a patient and giving them a big overview, because that rarely happens now. And
Yeah.
we have a great team of myofunctional therapists, ENTs, craniosacral therapists, functional medicine physicians, that we kind of look at our practice as the hub of the wheel, kind of medical central. We can't do all of this at our office. We can do certain things, but we can identify it. There's one accurate diagnosis, and then the way you treat it has it. That's where the multidisciplinary comes in. And I'm not qualified to diagnose, you know, what an ENT is qualified to diagnose, nor are they qualified to diagnose what I can
Right.
diagnose. That's why we've got to work together. And I would tell any patients that are listening to this, if you've got a one bullet solution, a MARPI or a MSE or a DNA appliance that is promises to solve all your problems, I might gently excuse myself from that practice and find one
Mhm.
that looks more at the overall picture, because that's what we have to be doing that, because it, like I said, the airway has to be patent from the nostrils all the way to the lungs. And like you said, there are other extraneous factors that, what medications are the patients on? What's their BMI? Um,
Right.
you know,
Right.
there are a lot of things, and some of those conversations are hard to have, especially with a 15-year-old girl that might be 85 pounds overweight.
Hmm.
But you do it out of love, you do it out of caring, and I think you it works.
Hmm.
You just have to look at more than just arch forms and teeth. And I think that's what you do, that's what we do, and that's what hopefully these podcasts, your teaching, my teaching, we can get more people doing this.
That's the goal. That's my why. It's
Yeah.
to start to just spread the word. And on that, I can't tell you how many people I've had reach out to me, and so many at that meeting who came up to me and said, "I listen to your podcast." And so again, I'm sure you have the same with you. And you don't realize the impact these podcasts have, but they'll say, like, I sent that to some orthodontic colleagues and they now think differently about this. Or, I had patients reach out to me because, as with you, I have a bunch of lay persons who will follow my show, and like, they heard you. I just literally had one email me yesterday asking for an orthodontist in the Southern Connecticut area who understands Airway. The parents and patients are listening to this stuff and they are going to ask these questions. So we owe it to our profession and we owe it to our patients to break free from those dogmas and change the fundamental way we deliver care. And I say to my orthodontic colleagues all the time, if we don't, there are people like yourself who deserve to eat our lunch, so to speak, orthodontically, because we're not doing it. And we can point fingers all day and say, he's not an orthodontist. He's not. No, we need to get over that ego trip and realize you're doing amazing things to help improve the quality of life of your patients. And we're also improving their quality of life, giving them a nice smile, but it's a totally different level of
Right.
quality of life if that patient is suffering to breathe, no matter how good their teeth look.
Well, if you make them breathe good, they're going to look better. I mean,
Oh, wait. Have you ever had a patient
always
that you
look
went
better.
in ever like and like developed the arches and got them growing the
Yeah.
right way that doesn't look amazing as a teenager?
Yeah.
Like it,
I
like,
always tell my patients, have you ever seen someone with stage 4 cancer, and then, they get cured, and, sometimes it's a miracle, sometimes it's the miracle of modern medicine, and you see them 2 years later, they look great.
yeah,
It's because they're healthy and their
yeah,
body is functioning properly, and that's going to be an aesthetic improvement, just in and of itself.
yeah.
Before we leave, I want you to, so I have the utmost respect for what you're doing, Mike,
Thank
because
you. Same to you.
I, for years, I was stabilizing joints and then restoring occlusion. I wouldn't touch a patient's teeth until we did that.
Mm.
And in the dental community, I was really looked up to. It's like dentists didn't do that, but they knew what I was doing was the right thing to do. So
Hmm.
it wasn't like I was being bashed by that. It was kind of like, golly, man, how do you do that? That's, you what you're doing is just the opposite. You're doing what's right and truthful, but your profession is not look they're not saying, yeah, we really need to be. I mean, they're throwing daggers at you. And when what you have on your side is the truth, and what you have on your side is your anecdotal evidence
Hmm.
by the health of your patients. I would like you to tell the story that you told, because I've told this to several patients
Hmm.
uh, when they say, "Well, my orthodontist does this," I have to say most patients that come to me anyway, it'd be kind of like an oncologist saying, 99% of the patients I see have cancer. Well, yeah, you're an oncologist.
Hmm.
99% of the patients I see have an airway issue because they're coming to me for that. But I know looking back that they almost all did. All my patients, most of them probably had an airway issue. You told the story about the high jumper, Fosbury, I think is his name.
Hmm. Dick Fosbury. Yep.
Yeah. Just tell that story quick. I think that would be a great way to end because it just kind of goes against the whole narrow-minded dogma way of thinking about things.
Yeah, happy to. So it goes along the line with the paradigm shift and with the concept that those who are out on the forefront of this oftentimes will take some daggers and take some arrows. And I appreciate the kind words on that. I really do. It's an interesting challenge. And when I do, I put myself in here knowing this would happen. So I have no one to blame but myself for it. But I actually I'm proud to serve in that role in that capacity because I really do feel it is making a difference, and it's like you said, a very worthwhile cause. But Dick Fosbury was a high jumper in the '60s, and he prior to Dick Fosbury coming along in the sport, people went headfirst over the bar. So they would run and they would jump up, and kind of common sense, right? You want to jump over the bar head first. He was the first one to develop the approach where you literally went up and went backward over the bar because he was kind of this gawky tall guy who just had trouble getting his limbs coordinated to jump head first. So he was ridiculed from the sport. People were making fun of him, mocking him for doing it. And until at the 1968 Olympics, he set the Olympic record with a jump of 7 feet 4.5 inches in 68. So we started to garner a little more attention for this as it started to show that it worked. And then today, as of today, literally in the 2024 Summer Games, every single athlete went over the bar backward, doing what is known as the Fosbury flop. And actually, the new Olympic record was set by a woman from Ukraine, Yaroslava. And I show in my lecture this picture of her just like soaring over the bar. Actually, I think it was the world record, soaring over the bar backward, and just it just shows, here he was 50 plus years earlier, mocked and ridiculed for this crazy idea that was like, why would you ever go over a bar backward? It's 180 degrees wrong. You are literally doing it 180 degrees incorrectly, and the opposite, so to speak, of what should be done. And now it's accepted as norm, and you don't see anybody doing it the old way. And I love that because I really do feel that is what people like yourself, your wife, myself, that we're doing is we are taking this whole sport, so to speak, and to draw the analogy, profession in our case, and we are turning it 180 degrees. And we're saying instead of reactively going over the bar first because it feels best and feels easiest, we're going to proactively flip and do it what seems like backward. But if you spend that extra time in the beginning and, like you said so well, in the diagnostics and the planning, man, the results are way better, and you'll be setting world records all the time with the results and the end results you get with your patients.
The Dick Fosbury of orthodontics, Mike.
Well, thank you. I'll take it. I'll take it. Thank you, Hal. I
Mike,
appreciate that.
it's been a privilege. I definitely want to have you on again.
Sure.
Thank you so much. This is
Love to.
Health and Harmony Beyond the Teeth. Dr. Hal Stewart with Dr. Mike DeLuke. It's been a great hour and right at an hour. So I might appreciate it. Have a great day.
Thanks so much, Al. You too.